de anemia plástica, le damos la bienvenida a esta sesión sabatina sobre hemoglobinuria paroxística nocturna. En mayo fue la celebración o conmemoración del HPN a nivel mundial, por eso decidimos hacer esta sesión y con dos grandes invitados que nos acompañan desde Leeds. Entonces, muchas gracias a ellos y va a ser una excelente sesión, así es que vamos a estar atentos toda esta mañana. Voy a dejar a la doctora Magda Ortiz, quien va a coordinar la sesión con los ponentes y con las preguntas al final de ambas presentaciones. Bienvenidos y feliz sábado.
Gracias, doctor Efren. Bueno, agradecemos al doctor Efren Montaño, el presidente de nuestra asociación, por participar y dar la bienvenida a nuestros dos grandes ponentes. Como él ya lo mencionó, el día de hoy tenemos una sesión especial. Es una sesión que para nosotros es muy significativo tener el día de hoy a dos grandes ponentes en el ámbito de hemoglobinuria paroxística nocturna. Ambos ponentes son médicos con un gran prestigio internacional, entonces para nosotros el día de hoy es muy importante, tendremos una sesión de lujo. El día de hoy empezaremos con la primer parte de nuestra sesión con la doctora Morag Griffin. La doctora Griffith es miembro de los médicos del Hospital de St. James en Leeds, en Reino Unido. La doctora es hematóloga por la Universidad de Dune. Ella hizo hematología en Sheffield y tiene aparte una maestría en liderazgo médico. La doctora es hematóloga y responsable del servicio de hemoglobinuria paroxística nocturna y anemia plástica. Y tiene interés especial en ambas patologías, además de histiocytosis. Es consultor en hematología y experto en HPN a nivel mundial y participa en múltiples ensayos clínicos sobre hemoglobinuria paroxística nocturna. Además, es miembro del grupo colaborativo de HPN y anemia plástica del EBMT. Entonces, bueno, la doctora tiene una amplia experiencia en todo lo que tiene que ver con este tema. El primer tema será dado por ella, lo cual para nosotros es muy, muy interesante. Continuaremos posteriormente con un tema también igual importante, en el cual vamos a ver de cómo se trata en este tiempo, en el 2025, la hemoglobinuria paroxística nocturna. Esta plática, que también es muy importante, nos hará el favor de darla el doctor Richard Kelly. El doctor Kelly también trabaja en el Hospital de St. James en Leeds, en Reino Unido. Y el doctor Kelly también es uno de los grandes expertos en el tema de hemoglobinuria paroxística nocturna. Él también es hematólogo consultor para hemoglobinuria paroxística nocturna y él estudió en San Andrews, siendo graduado con honores. Completó su formación en Manchester y su tesis doctoral le valió un grado honorífico, que el tema fue precisamente fisiopatología en HPN. Y él, bueno, también ha sido uno de los grandes estudiosos en este ámbito de la hemoglobinuria paroxística nocturna, pero no solamente se limita a hemoglobinuria paroxística, también estudia sobre aplasias medulares, leucemia linfoblástica aguda, leucemia mieloide aguda y anemia hemolítica. Él también es miembro del Real Colegio de Patólogos del Reino Unido, de la Sociedad Británica de Hematología. Entonces, bueno, ambos son grandes expertos y líderes en el tema, por lo cual nosotros agradecemos el día de hoy que estén con nosotros. Y bueno, pues empezaremos nuestro primer tema con la doctora Griffith. Doctora Griffith, muchísimas gracias por participar el día de hoy en nuestra sesión. Para nuestra asociación es de gran interés el tema y tener personas como usted es algo muy importante. Entonces, sin más, dejamos a la doctora Morag Griffin para su tema de fisiopatología, trombosis y clasificación de HPN. Mil gracias.
Thank you very much for the kind introduction and the invite to speak to you on a Saturday morning. Can I just confirm that you can see my slides?
Yes, Morag.
So I'm going to cover the background of PNH, some case studies, the pathophysiology, thrombosis, indications for testing, and something on pregnancy. So PNH is considered an ultra-rare or ultra-orphan disease, and a rare disease is defined in Europe and around the world as less than 5 cases per 10,000 or less than 500 cases per million. For patients with rare disease, it often takes quite a long time to reach a diagnosis, and certainly, although we are making improvements with PNH, some patients still have quite a long trajectory to reach a diagnosis, and some patients are often misdiagnosed, and certainly we see that in PNH, where patients are referred to a variety of clinicians that aren't haematologists, depending on their presenting symptoms. So for PNH in the UK, the estimated prevalence is around 15 to 40 individuals per million, very similar in the US, and the median age at diagnosis is 35.5 years. PNH can, however, affect anybody at any age, and our youngest patient was 5, now 11, and our oldest patients are in their 90s. You can see from the Kaplan-Meier graph on the right, prior to complement inhibition being available, prognosis from PNH was limited with a reduced life expectancy. And this is sadly the case still for a lot of patients in countries around the world where treatment is not available. And so what is PNH? Normal blood cells have GPI anchor proteins, which bind various surface proteins, and a PIGA gene codes for various GPI anchors. In PNH, there's a PIGA gene mutation, which results in the lack of GPI anchor proteins being synthesized, and therefore, in particular for red blood cells, they lack CD55 and CD59, but also for other hematopoietic cells, and therefore they're not protected within the circulation. As we've already mentioned, PNH can affect adults and children. Children tend to have smaller PNH clones with a higher incidence of aplastic anemia with a PNH clone in the background, but we do see hemolytic patients below the age of 18. In terms of the mechanism of disease, PNH is an acquired disorder, so patients acquire a PIGA mutation, which results in a loss of GPI anchor proteins and a gradual expansion of the PIGA deficient cells over time. This results in a process of intravascular hemolysis. In a PNH presentation, we have to have a discussion about complement, which we're all very fond of. As you can see, and I'm sure many of you are familiar with looking at these diagrams, there's a classical, lectin, and alternative pathways. The complement regulators, as you can see highlighted here, are CD55 and CD59. They are negative regulators of complement, and therefore, usually when present, the complement system is in a resting state, but when presented with a pathogen is activated, results in membrane attack complex formation, destruction of the pathogen, and then goes back to the resting state. However, in PNH, as we know, patients lack CD55 and CD59, resulting in permanent activation of the complement system. This results in terminal complement activation, C5 through to C9, and the MAC formation. This results in intravascular hemolysis, the release of free hemoglobin, and nitric oxide depletion, which gives rise to many symptoms which patients experience. You also get platelet aggregation and leukocyte activation, which contributes to the risk of thrombosis, which I will discuss in due course. Release of free hemoglobin and reduction in nitric oxide results in symptoms such as abdominal pain due to loss of smooth muscle relaxation, and patients often complain of abdominal pain which lasts a couple of days and can be quite severe to the point they may reduce their oral intake and start to lose weight. Dysphagia due to dysmotility of the esophagus, significant fatigue due to the process of intravascular hemolysis and associated anemia, hemoglobinuria due to release of free hemoglobin and the effects on the renal system, and erectile dysfunction, again due to the loss of smooth muscle relaxation. a significant increased risk of thrombosis, which I will discuss, and the complications you can associate with PNH, including renal failure and pulmonary hypertension. And so I've got a couple of cases through this, and this is a 26-year-old gentleman who was diagnosed after he came over to the UK. He was in a different country, and he presented with a 2-year history of hemoglobinuria. As you can see from the top, he'd been to multiple hospitals between the ages of 2013 and 2021 when he moved to the UK. His hemoglobinuria was considered trauma-related and was misdiagnosed as hematuria initially. He'd had a lot of GI symptoms to the point he'd had an appendicectomy, an exploratory laparotomy, and various other surgical procedures. On admission to the UK, on arrival to the UK, had marked anemia with a hemoglobin of 66, a high LDH, and he was referred to haematology for iron deficiency anemia and transfusions, which you can all agree that in a young man, there must be something underlying this. And so in terms of PNH disease burden, and this is a web-based survey of 163 patients from the AAMDS Foundation, 37% of patients were diagnosed with more than 2 years after onset of symptoms, and our patients are with a median age of 35, often are partaking in normal work, life and busy activities, don't think much of some tiredness. 48% of patients were unable to maintain employment following a PNH diagnosis, although I would hope to say that I think this has improved. And 11% of patients were referred for mental health evaluation rather than a diagnosis of PNH. But you can see on the graph here that the majority of symptoms were overwhelming fatigue, weakness, and shortness of breath. In terms of physician-reported symptoms by baseline, stratified by GPI deficient granulocytes, the symptoms, as you would expect, are higher with a PNH clone of greater than 50%. And this is the light blue graph here with around 50% of reports of abdominal pain, marked increase in dysphagia, dyspnea, erectile dysfunction, fatigue, and hemoglobinuria. But you'll note that fatigue is a very difficult symptom to quantify. Patients with a PNH clone less than 10% also had quite significant fatigue. And I think this comes down to the overlap of aplastic anemia and PNH, where a lot of these patients with the smaller PNH clones will have underlying aplastic anemia and therefore be fatigued due to their anemia from this. So we know that you can stratify symptoms and based on LDH, and the higher the LDH, the more hemolytic we could consider a patient. And this is data from the Korean registry with patients with a high LDH greater than 1.5 times the upper limit of normal compared to those with an LDH less than 1.5 times the upper limit of normal. And you'll note there is quite a significant increase in symptoms stratified by LDH. So abdominal pain is clinically significant, more common with a high LDH compared to a lower LDH, and very similar for other symptoms such as pain, chest pain, and hemoglobinuria. So our patient was diagnosed with PNH and in 2023 and was commenced on ravulizumab with good effect. The LDH came down very quickly and the hemoglobin did stabilize around about 100, 110. So in terms of our second case, this is a patient with a 52-year-old man who presented with deranged liver function to his general practitioner, had a high alcohol intake, which was assumed to be the cause for his high ALT, and a gamma GT, but actually on further questioning, he had lost around 4.5 stone in weight due to not eating with abdominal pain. He'd decided his erectile dysfunction was related to his age, and he'd been to his primary care physician several times already. He was rushed into hospital in 2020 with a deranged liver function, and as you can see on the right-hand side, quite a lot of his liver is a dusky colour, and he had a significant hepatic thrombosis, the Budd-Chiari. As we advise all of our hepatology colleagues, if they're checking a JAK2 and a CALR in the situation of liver pathology, please do a PNH screen as well here. the liver registrar was contacted our haematology registrar, who advised PNH green, and as you can see, had a high proportion of PNH cells. The patient had a venogram and angioplasty with an outflow stenosis and clots in the central segment of the right and left hepatic veins, which was cleared by TPA and balloon trawling. But you can see when we did specific blood tests, his LDH was extremely high, and he had a compensated reticulocytosis as well. Looking at the PNH diagnostic flow plots on the bottom, looking for a negative GPI anchor population, you can see there's a large PNH clone on the bottom left-hand side of the monocyte and the neutrophils. And so thrombosis is a leading cause of death in PNH, and 20 to 67% of PNH patients die from thrombosis. I think this is significantly reduced now, and certainly data from the TRIUMPH study, which will be discussed in the treatment section, has shown this. There's a relative risk of 60 times higher than the general population, and actually it's a very thrombophilic condition and higher incidence of thrombosis than things like factor V Leiden and other clotting disorders that we're familiar with. For patients with a PNH clone, more than 50% who are not on treatment because they have no indication to have complement inhibition, we anticoagulate them with a direct oral anticoagulant. PNH is a clinical emergency. A PNH-related thrombosis is a clinical emergency requiring immediate treatment, and we offer a 24-hour on-call service in the UK, so patients can have direct access to treatment if they're unwell over the weekend, and we've certainly activated this weekend. From the diagrams on the bottom right-hand side, there's PNH-related dermal thrombosis, which I think we all worry about, but certainly I've only seen once in the last 10 years. And so we know, this is data again from a Korean registry from 2016, that patients with, this is without treatment, without complement inhibition, patients who have thromboembolic disease have a significantly poorer prognosis in the absence of complement inhibition compared to those that don't have a thromboembolism, with a 14-fold higher mortality rate compared to the general population. When we look at the distribution of thromboembolism in PNH, then around 20% of them can be arterial, including cerebrovascular events and cardiac events. And we've certainly had patients present with multiple thromboses, including cardiac events and clotting off of cardiac stents. But patients can also present with a deep vein thrombosis or a pulmonary embolism and the classical hepatic or portal vein thrombosis that we've talked about already. And so thrombosis pathophysiology in PNH is quite complicated, and certainly there's a lot that we still don't understand. The interaction with the clotting system and the hematopoietic system is closely linked, and the combination of neutrophil and platelet activation, as well as endothelial dysfunction, platelet microparticles, and as well the process of intravascular hemolysis all contribute to PNH-related thrombosis. So moving on to renal impairment. Renal impairment is relatively common in patients with PNH, and certainly we've had patients present with acute renal failure. We had a couple last year, fortunately reversible as it was identified quickly, and they started on complement inhibition. 64% of patients have evidence of stage 1 to 5 renal impairment, and if you look on MRI, around 80% will have evidence of renal siderosis. Patients do report urine being very dark, and we certainly do ask our patients whether it's a Coca-Cola or a red wine coloured urine, and certainly at 7 o'clock in the morning, as you can see, it gets lighter throughout the day. It's quite useful because most patients do have dark urine in the morning to be able to say, does it look like Coca-Cola or is it just normal overnight dehydration? Again, looking at data from the Korean registry, those with renal failure had a poorer outcome compared to those without renal failure, and therefore complement inhibition in this situation is essential. And so who should we test for PNH? Many of you will be familiar with the CATCH criteria, but unexplained cytopenias, and aplastic anemia, refractory anemia with MDS, are the relatively straightforward patients, and 40 to 60% of patients with aplastic anemia will have some degree of a PNH clone. Those with unexplained thrombosis, so the young patients who've had a stroke that are being investigated with a variety of neurological investigations for cause of stroke, add a PNH screen on. Those with recurrent thrombosis or cytopenias associated with thrombosis, again, check for PNH. It's relatively easy to do, and it's a quick diagnosis to rule in or rule out. The classical Coombs negative hemolytic anemia is, again, straightforward. There's very few conditions which will give you Coombs negative hemolytic anemia. And then hemoglobinuria, we do education for certainly urologists, as a lot of our patients, as I'm sure a lot of your patients, quite often present via urology with misdiagnosed hematuria and have had cystoscopies and a variety of investigations. PNH should be diagnosed by flow cytometry for red cells and by FLAIR for white cells using several different markers, and we would always want a white cell clone check as well as a red cell clone, because patients with PNH, if they're having intravascular hemolysis, will have a relatively disproportionately low red cell clone compared to the white cell clone as they're hemolyzing. So you may get false reassurance if you're only looking at a red cell clone. And so these 4 graphs are patients who've all been within our service, and the importance of PNH clone monitoring. The current guidelines advise PNH checks certainly for most patients every 3 to 6 months for the first couple of years, and then less frequently thereafter. This patient on the left had a relatively stable course from 2013 to 2018. And then rapidly expanded their clone. They'd actually had a progressive aplastic anemia, and the PNH clone expanded on recovery from treatment. A fairly standard PNH clone monitoring on the right. As you can see, there's a discrepancy between the red cell clone and the white cell clone. This patient was being observed and wasn't on any complement inhibition. And then around 10% of patients will remit their clone over time. And as you can see, this patient started off with a PNH clone at 70% in 2010, and then by 2020 had remitted their clone. We do ask or advise where appropriate to do so that patients undergo a bone marrow test if they reach a clone of 10% to ensure that they're not clonally evolving an underlying myeloid disorder. But we also stop their complement inhibition when they reach 10% as they no longer need it. And so if this patient hadn't had their clone monitored, then they would be having unnecessary treatment. And then this patient on the right-hand side had a significant PNH clone, as you can see, and then had a sudden fall from their PNH clone. They had a transplant in 2020 for the underlying cause of aplastic anemia, and their PNH clone rapidly remitted, and then they stopped their complement inhibition. And so how do we classify PNH? The classical PNH that many of us are very familiar with a markedly abnormal LDH, and this is from Charles Parker's paper based on the IPIG guidelines. High LDH, a cellular marrow with erythroid expansion, which we very regularly see in a large population of PNH cells. As we've already discussed, PNH in the setting of another bone marrow failure disorder can be quite difficult to treat, particularly if you've got a moderate PNH clone. We would advise treating the underlying aplastic anemia as per guidelines and being there to treat the PNH if needed. And then subclinical PNH, so no clinical or biochemical evidence of intravascular hemolysis, but likely has an concomitant bone marrow failure, so PNH clone less than 10%. And many of you will be very familiar with the overlapping conditions where PNH sits, with the overlap of PNH and aplastic anemia, as I've already suggested, but we do see some patients going on to develop myelodysplasia or acute myeloid leukemia in a small number of patients with clonal evolution of the bone marrow. And not all patients fit the criteria of classical, intermediate or subclinical PNH. And this is a small cohort of patients that we reported in 2018 with the concurrent disorders of aplastic anemia and PNH, and you'll see a large granulocyte cell population diagnosed at the same time as their aplastic anemia. And these patients can be very difficult to decide which needs treatment first, but the aplastic anemia should be treated as per guidelines, and you can always treat the PNH concurrently with approved treatment options. So our patient with the thrombosis presented in December immediately started on eculizumab, which was the available treatment at the time. As you can see, his LDH fell quite swiftly and dramatically. He had quite a difficult time of it. He developed vaccine-induced thrombocytopenia from the COVID vaccine, and also developed a transfusion requirement, which got quite complicated. But from a PNH thrombosis point of view, he was well managed. Richard will talk about this in more detail, but these are the current approved indications for treatment in the UK. And as you can see, thrombosis is at the top, clinical emergency of which eculizumab, ravulizumab, crovalimab are all approved in the UK. Pegcetacoplan in the US, we don't use it in the naive setting in the UK. And so moving on to pregnancy, briefly in the last couple of slides, patients with PNH are advised not to get pregnant prior to eculizumab, with a relatively high maternal death rate, particularly in the postpartum period, a fetal death rate and a 50% preterm delivery. There's also a risk of relapse of aplastic anemia with the concurrent disorders of PNH and aplastic anemia, which is very difficult to counsel patients for. And so this lady actually did get pregnant in 1996 prior to any treatment being available, and as you can see, had a hemoglobin of 91 or 9.1 and platelets of 65. At the time was assumed to be immune thrombocytopenia, and actually had an IVIG and some steroids, which clearly didn't do very much. There was no treatment available for PNH at the time, as she was anticoagulated and delivered a healthy baby boy. However, in 2013, so a number of years later, she had a second pregnancy and commenced eculizumab. In 2014, she had a further, she came off eculizumab following pregnancy, as the only indication was for pregnancy, but then had a thrombosis with her PNH clone in 2014 and recommenced eculizumab. But you'll see during her second pregnancy, and we see that around 2/3 of our ladies need a higher than standard dose of eculizumab in the second and third trimesters. She started treatment around 11 weeks of pregnancy, and her LDH was very well controlled. Sorry, this is LDH here. And then at 31, she had a biochemical breakthrough, not a clinical breakthrough, but a biochemical breakthrough, and with a trough LDH being raised at 1,500. And her dose was increased. Her dose was further increased around delivery, and then she came off treatment at 3 months postpartum, which would be our standard process. And there are a small number of ladies who have a PNH clone over 20%, but no other indications for complement inhibition except pregnancy do come off treatment. She had a subsequent DVT a couple of months later and did go back on treatment. And you'll see her LDH was around 3,000 at the time. She had a third pregnancy in 2016, which was actually quite a difficult and complicated pregnancy, but she was already on eculizumab at the time. But you'll see she had a spike in her LDH at 15 weeks, so quite early on in her second trimester, and required to go up to 1,200 milligrams every 2 weeks, and then quite swiftly went up to 1,500 milligrams, and then at 30 weeks, she ended up on weekly eculizumab. So really quite an onerous pregnancy for her, but she had a successful vaginal delivery and then went back down on her dose of eculizumab. And so in terms of management of pregnancy, we do a lot of counselling for our ladies of childbearing age, and we ask once they have a confirmed pregnancy to let us know. We refer them to Haematology Obstetric Clinic. If they're already on eculizumab, then we start low molecular weight heparin treatment dose where safe to do so, and provided the platelet count is safe, which then continues for 3 months postpartum. We monitor the LDH and trough LDH from about week 16, and if they've have a biochemical or a clinical breakthrough, which we hope they don't, then we would increase the dose of eculizumab and then reduce it back down at 3 months postpartum. For those ladies not on eculizumab with a PNH granulocyte cone of greater than 20%, we commence eculizumab towards the end of the first trimester and low molecular weight heparin. And as I've already alluded to, we stop the eculizumab 3 months postpartum if their only indication was for pregnancy. If they're not on eculizumab, but they've got a granulocyte cone of 10 to 20%, we have had a small number of ladies expand their PNH clone during pregnancy. And if it goes over 20%, then we would start them on eculizumab. We also anticoagulate these ladies with low molecular weight heparin, which continues for 3 months postpartum. So many of you will have seen Dr. Kelly's paper from 2015 and some subsequent meta-analysis that have been published as well. But there was no maternal deaths and the preterm delivery has reduced to 29%. Still remaining a small risk of fetal death. And eculizumab is detectable in low levels in cord blood, but ladies can breastfeed. The babies have normal complement activities. Currently, we're only using eculizumab during pregnancy. There is a small case series of patients published using ravulizumab in pregnancy, and there's 2 case reports of patients with pegcetacoplan, but we certainly are currently using eculizumab. In terms of contraception and fertility in PNH, we would advise ladies to use a low-dose progesterone-only medication or barrier contraception, avoiding estrogen. And there's no reduction in fertility. In terms of HRT, we quite often get asked questions about whether ladies can have HRT, and we would normally advise them to try and seek alternative management for menopause before considering HRT, and if they need to have HRT, to use the lowest estrogen-based option available. So we remain with many challenges in PNH, starting with the recognition of PNH, and we all do a lot of education around this. Diagnosis and availability of testing, certainly in the UK, Europe and your countries, testing is available, but testing in other countries without treatment availability is difficult. Identifying who needs treatment, and not all patients with PNH with a PNH clone need treatment. We need to have symptoms, and clinical trial availability. We normally try and have a clinical trial available for patients at all times. We have a naive trial open at the moment. Assessing response to treatment, which Dr. Kelly will cover, and lifestyle factors. The patients are young. They don't want to be diagnosed with a chronic hematological disorder in their 30s or even younger, and it can take quite a long time to psychologically adapt to this. We encourage people to engage with our PNH support group, who are very helpful and also offer various webinars to provide support and psychology aspects. And just briefly, this is our website on the screen. There's a lot of information on there. We have around 1,100 patients within the service between us and the King's team in London. We go out and do outreach clinics around the UK, as you can see. We're in the middle at Leeds, and we go up to Scotland, which is up here, and various other outreach locations around the UK. So the patients come and see us in clinic in their nearest clinic available, rather than having to travel a long way. We also do video calls. We're using a video software program for patients as well. We have 5 consultants within the service, 4 clinical nurse specialists, an advanced clinical practitioner, and a large proportion of administration staff, as well as a staff grade. As I've already mentioned, we have a 24-hour on-call service for patients to contact us if they're unwell or they have a temperature, to manage their admission to hospital and provide education to the local team where they live about meningococcal infection risk if they're on a complement inhibitor, and also to manage thrombosis risk as well if a patient's had a PNH-related thrombosis. So PNH is a rare and life-threatening condition, and it presents to a variety of different specialties. We've already discussed urology, but they may go to gastroenterology, particularly if they've got dysphagia or abdominal pain. They may present with a pulmonary embolus to respiratory. Recognizing PNH can be very challenging. Pregnancy is now possible, and it's still considered a high-risk situation, but we have supported many ladies through pregnancy. And there's a significant overlap with bone marrow failure. We remain with many challenges, and I thank you very much for listening.
Muchas gracias, doctora Griffith. Sin duda una presentación magistral, muy bonita. Creo que a todos nos ha quedado claro muy bien lo de las etapas del HPN. Le quisiéramos pedir si nos podríamos reservar al final las preguntas para poder continuar con el siguiente tema, doctora. Muchas gracias. Bueno, pues agradecemos a la doctora Griffith por su excelente participación. Como ustedes vieron, la doctora es una gran experta. Es un sueño para nosotros en México poder tener grupos de apoyo, tanto para anemia plástica como para hemoglobinuria, paroxística, anemia de Fanconi y otro tipo de entidades que son raras. Es que es muy difícil poder tener expertos en todos los hospitales. Entonces, esta es una de las propuestas que nosotros como grupo de la Asociación Mexicana de Anemia Plástica vamos a tener para el siguiente Congreso de Hematología. Esperamos contar con la participación de todos ustedes. Va a ser el sábado del Congreso. Entonces, creo que nosotros tendríamos que aprender muchísimo de todo lo que se está haciendo en los países grandes como en Reino Unido, como en Europa, en donde se busca tener un experto que pueda ser consultor para todos los demás grupos. Esto es algo que sin duda puede beneficiar a muchos de nuestros pacientes aquí en México. Y bueno, continuando con nuestro programa, tenemos la participación del doctor Robert Kelly. La verdad es que para nosotros también es alguien muy importante poder contar con la participación del doctor. Él nos va a hablar ahora en el 2025 cómo podríamos tratar a los pacientes con hemoglobinuria paroxística nocturna. La doctora ya adelantó un poquito de lo de qué es el tratamiento para estos pacientes, pero bueno, vamos a ver la plática del doctor Robert, vamos a ver cómo podríamos hacer nosotros para poder manejar a nuestros pacientes. Este tipo de pacientes son pacientes que, que tienen una características muy particulares. Entonces el doctor Richard Kelly va a ser alguien que nos va a poder apoyar muchísimo con lo que es el tratamiento del paciente en el 2025 con HPN. Muchas gracias, doctor. Les agradeceríamos a todos también que recuerden que tenemos el traducción para los que lo necesiten. Están las indicaciones en el chat. También si quisieran empezar a hacer sus preguntas en el chat, y en breve en el chat vamos a estar compartiendo para que registren su asistencia. Mil gracias. Doctor Richard.
Thank you. I'll just share. One sec.
Doctor Richard. Sí, muchas gracias. Bueno, en lo que el doctor Kelly inicia su presentación, en el chat están las indicaciones para los que necesiten traducción. También por vía chat pueden empezar a anotar sus preguntas. Si alguien tiene alguna pregunta, o pueden hacerlo en directo también con alguno de nuestros ponentes. Contamos con el servicio de traducción. Y como les comenté, esta es una sesión especial. La hacemos el día de hoy en sábado, por lo cual agradecemos también a nuestros ponentes por el cambio de horario, que es algo pues difícil a veces poder hacer las pláticas en sábado en la tarde. Sin embargo, el día de hoy para nosotros es muy importante. Esta sesión especial es debido a que fue el día del HPN en el mes de mayo. Muchas gracias.
So firstly, thank you very much. Thank you for inviting me. Very privileged to speak with you today. Can you see my slides move? Can you see them moving? Can you just confirm?
Sí,
Thank you. So I'm going to talk about treatment of PNH in the current era. These are my disclosures. So we are very fortunate in the UK. We are able to use all the available anti-complement therapies that have been approved. So we are able to treat patients with C5 inhibition with eculizumab, ravulizumab, crovalimab, and eculizumab biosimilars. And we're also able to use proximal inhibition with pegcetacoplan, iptacopan, and adding dinicapam to a C5 inhibitor. So in terms of who we treat first, we treat patients who have a thrombosis, who have hemolytic disease, so an LDH greater than 1.5 times the upper limit of normal, with symptomatic PNH, who are anemic, or who are transfusion dependent. We treat patients who have significant complications because of their intravascular hemolysis, so pulmonary hypertension, severe renal impairment, as Morag has talked about. And again, we treat patients who become pregnant and for at least 3 months after the pregnancy has been completed. And then there's a group of patients who we treat who don't fill these criteria. These are patients who either have extreme fatigue or who need complex surgery or chemotherapy. And you can see from the table as to which of the products we use in first-line treatment. So this is in naive patients. Just to give an idea of the types of issues that we treat patients for, this is data from our annual reports from the previous year. And you can see by far the majority are hemolytic patients, and then the next highest category is thrombosis. So when we think about treatment for patients, and this overlaps slightly with what Morag said, but I think this is what we should aspire to with our patients. So we provide a 24-hour on-call service. So if they're unwell, they are able to contact a PNH specialist. This is especially important for patients on anti-complement therapy, whether they get breakthrough hemolysis or whether they get an infection, especially meningococcal infection, to be able to speak to a specialist at any time is important. It's often these cases are often challenging and difficult, and having conversations with other specialists through MDT meetings are important, and having regular morbidity and mortality meetings to make sure that everything was done correctly for the patient. I think it's important to have regular histology. Often when patients are referred to us, they have a diagnosis of myelodysplastic syndrome, but usually it turns out that they have underlying aplastic anemia rather than MDS. We provide advice about aplastic anemia due to the association with aplastic anemia, and participate in clinical trials. And I think where possible, this is what we should all be looking to do for the patients that we have with PNH. There are quite a number of different pharmacological therapies now for patients with PNH. We've been using C5 inhibition since the first patient was treated at our centre in 2002 with eculizumab. We've now have better drugs, I would say, than eculizumab in terms of ravulizumab and crovalimab blocking at C5, and I'll also talk about proximal complement inhibition, and you can see where those proximal inhibitors are acting on the cartoon. So what about C5 inhibition first? This has been and is the mainstay of treatment for most patients who have complement therapy available. Eculizumab, crovalimab, ravulizumab bind to C5, preventing it from being cleaved and thereby preventing the formation of the membrane attack complex and stopping intravascular hemolysis occurring and its consequences. Eculizumab was first used in 11 patients in a pilot study. Because of the benefits in that pilot study, there was a pivotal phase 3 double-blind placebo-controlled trial. And on the small graph on the left, you can see the patients on placebo were all transfused during the study, whereas the patients receiving eculizumab, only a minority needed transfusions. The Shepherd study was then a broader study, allowing for patients requiring less transfusions and allowing for patients who had lower platelet count, insinuating that they're more similar to a real-world population. In all of the studies, LDH, which is an important biomarker in PNH and is very high in patients with hemolytic disease because of the hemolysis, whenever eculizumab was initiated, the LDH levels drop down very quickly. And they remain at or below the upper limit of normal whilst patients remain on eculizumab. The very first patient I saw was a young female patient. She had been on anticoagulation with warfarin, and she came into hospital with a high INR. She was given fresh frozen plasma, and the team looking after her stopped her warfarin. Fresh frozen plasma is full of complement, and she developed multiple thromboses, as you can see from the list of thromboses on the left, in a very short period of time. When I first met her in February 2005, she had bowel ischemia, she was on the intensive care unit, had ascites, and was extremely unwell. And we were fortunate to persuade the surgeons not to take her to theatre. They wanted to operate on her bowel. When the Shepherd study opened, we tried to get her into the study, but because she was needing so frequent transfusions, her PNH level was less than a red cell percentage of less than 10%. So we held off transfusing her for 10 days. Her red cell clone increased, and she was able to enter into the study. This patient remains well, remains under our service. She's had no more thromboses. And she completed a degree in forensic medicine, and she's the only patient I think that we have advised not to try to become pregnant because of how unwell she was, and she has adopted 3 children instead. Eculizumab is extremely effective at reducing thrombosis in PNH. It doesn't get rid of the risk, but it dramatically reduces the risk, and this is seen whichever study you're looking at, or the Alexian International Registry. So we know blocking at C5 with eculizumab reduces LDH levels, improves hemoglobin levels, increases facet fatigue scores, so patients have clinically relevant less fatigue, reduces thrombotic events, stabilizes or improves renal function. The kidneys are the only organ that can deal with fragmented red cells in PNH, and by stopping intravascular hemolysis, the kidney function either improves or stabilizes in the majority, and there's less pulmonary hypertension present. So what about the newer drugs? So our practice, we have almost entirely switched from eculizumab to ravulizumab in those patients who were on eculizumab. There is good clinical trial data to show that ravulizumab is non-inferior to eculizumab. There are 4 amino acids different in ravulizumab compared with eculizumab. In the majority, patients find it much easier because instead of having to be given every 2 weeks by intravenous infusion, it's given every 8 weeks. And we've had multiple patients who said that they can forget about their PNH for 2 months, and they're not having to worry about when their next infusion is 2 weeks later. It's shown to reduce the risk of thrombosis and improve overall survival. So what about our experience in terms of eculizumab and ravulizumab? So we published our experience of 509 consecutive patients treated in the United Kingdom from May 2002 to July 22, and we looked at the characteristics of the patients and their outcomes on treatment. So this table shows the baseline characteristics. The average age was just under 44 years, similar male to female ratio. The median granulocyte clone was high, as you would expect for patients needing anticomplement therapy. Where there was a documented history of bone marrow failure, in the main that was aplastic anemia rather than myelodysplastic syndrome, and more than a quarter of our patients had had a prior thrombosis. And you can see the symptoms that they had when their disease presented in the bottom half of the graph. The thrombosis reduction is very dramatic with eculizumab and ravulizumab. So we had 23 thrombotic events in the patients from 2002 to 2022. We had 11 cases of Neisseria meningitidis. This was largely sepsis, although one patient had definite signs of meningitis, and we had one fatality. And sadly, the person who died didn't contact us for more than 72 hours. A small proportion of patients have clonal evolution, either to high-risk myelodysplastic syndrome or to acute myeloid leukemia, and we had 91 deaths. The hemoglobin at 12 and 24 months after being on a C5 inhibitor was stable, but the majority had a mild anemia. So only 1 in 5 of our patients had a normalization of their hemoglobin on eculizumab and ravulizumab, and there was a significant proportion still requiring transfusions in the most recent 12 months on eculizumab or ravulizumab. On the left is the overall survival for these 509 patients. The red line is age and sex match controls, and the blue line is what we saw in our patients. So what we did, because we were slightly concerned when we saw this initially, we looked at patients needing treatment for aplastic anemia. Just wonder whether I've got it on the next slide. No. So there were about 50 patients who'd had an allogeneic bone marrow transplant, mostly for aplastic anemia, but some for myelodysplastic syndrome, and a similar number who were on specific treatment for aplastic anemia, so immunosuppression with cyclosporine or tacrolimus, L-thrombopag, androgens. And so when we excluded these patients, there was 120, there was still 389 patients, so still a huge cohort of patients. And you can see on the right that by doing that, by removing the patients needing treatment for aplasia, the survival is very similar to that of age and sex match controls. What about other C5 inhibitors? So crovalimab is available as a first-line therapy in patients in the UK. So I'll just show you a couple of slides on trial data. So this was the Commodore 2 study comparing crovalimab with eculizumab. So the treatment period was for 24 weeks, and then the patients on eculizumab could switch over to crovalimab. The baseline characteristics were broadly similar in terms of eculizumab and crovalimab, and what you can see is non-inferiority. So similar with ravulizumab, crovalimab has a similar effect for patients that are treated, with a reduction in LDH levels and improvement in hemoglobin and transfusion requirements. So the benefit of crovalimab compared to eculizumab or ravulizumab is it's a subcutaneous treatment. And certainly in the UK, we can teach patients to self-administer, giving them more freedom from having a healthcare professional treat them. For eculizumab and ravulizumab, all our patients are treated at home by a team of home care nurses, which is an extension of our service. So can we do better than C5 inhibition? What else can we do? The main reason we need to think about doing better is about symptoms that patients on C5 inhibition can still have. So fatigue is the commonest reported PNH symptom. From a study on the left, you can see just over 61% of patients on eculizumab and just over 68% of patients reporting fatigue. We also know that patients on C5 inhibition, looking at patients from a European study, have lower aortic QLQ C30 health scores. Now, this tool is a tool designed for patients on chemotherapy, but it's used in most of the anti-complement trials, and it is a measure of global health, and this is lower on a C5 inhibitor than for someone without PNH. Why are these patients fatigued? Well, if you look at transfusion requirements, so there's a proportion of patients that have ongoing anemia on C5 inhibition, and you can see from these three studies, whether it's on eculizumab, ravulizumab, or a combination of both, like our study, there's 23 to 27% of patients requiring ongoing transfusions. So why is this? If we block the complement pathway at C5, the earlier parts of complement remain active. And when C3 splits into C3a and C3b, you get opsonization of the PNH erythrocytes in the bloodstream, which marks them to be removed from the circulation. So instead of lasting for 120 days like a normal red cell, they have a reduced life expectancy in the bloodstream, and this causes the ongoing anemia that we see due to extravascular hemolysis. What can we do to combat extravascular hemolysis? We can look to block the immune system earlier, before C3a and C3b are formed. So if we can block the complement pathway and prevent C3 being cleaved, then we won't cause extravascular hemolysis. So pegcetacoplan was the first proximal inhibitor to be developed and used. It has two mechanisms of action. It binds to C3, preventing C3 convertase, converting C3 into C3a and C3b, so preventing opsonization of PNH erythrocytes, but it also binds to C3b, preventing its integration into C5 convertase complexes. So it prevents intravascular hemolysis, but doesn't cause extravascular hemolysis. The pivotal study in terms of pegcetacoplan was the Pegasus study. So patients who were anemic on a stable dose of eculizumab were treated with eculizumab and pegcetacoplan for 4 weeks, and then there was a 1-to-1 randomization for the patients to continue either on pegcetacoplan or on eculizumab for 16 weeks. The primary analysis was at 16 weeks, and then patients could switch over to pegcetacoplan from eculizumab. When you look at the mean hemoglobin at the start of the study, the mean hemoglobin was 8.7. On eculizumab and pegcetacoplan together, this increased up to just under 12. In the patients remaining on pegcetacoplan monotherapy, the hemoglobin remained around this level out to week 48. The patients who went back to eculizumab monotherapy, that you can see the hemoglobin dropped quite quickly, but then when they switched back to pegcetacoplan at week 16, the hemoglobin improved again and was maintained out to week 48. If you look at the left, so this is the first blue bar is the patients on pegcetacoplan out to week 16, so over 85% of them did not require a transfusion. The grey bar is those on eculizumab, so only just over 15% of patients on eculizumab did not require a transfusion in that 16-week period. When you go out to 48 weeks, it's over 70% of the patients on pegcetacoplan not requiring transfusions, and we see a benefit in patients who either have lower levels of transfusions, so less than 4 transfusions, or more than 4 transfusions in the 6 months prior to going on to the Pegasus study. What about other proximal inhibitors? So dinicapam is a factor D inhibitor. So this is an important component of the alternative pathway. Now, dinicapam on its own, whilst showing some effects, it isn't enough to control intravascular hemolysis. So dinicapam has been evaluated in combination with either eculizumab or ravulizumab, and the pivotal study was the ALPHA study. So this was a study comparing dinicapam with placebo as an add-on therapy to eculizumab or ravulizumab. So dinicapam is an oral therapy taken 3 times a day, initially at a dose of 150 milligrams. But if you're not getting an optimal response, you can increase that to 200 milligrams 3 times a day. You can see marked improvements in hemoglobin levels in the patients on dinicapam in the dark blue line compared to those on placebo on the red line. And it always surprises me how quickly patients who have extravascular hemolysis, when they're treated with either pegcetacoplan, dinicapam, or iptacopan, as we'll see in a moment, how quickly their hemoglobin levels improve. In terms of secondary endpoints, nearly 60% had a more than 2 gram increase in hemoglobin. So these were patients who were anemic on a stable dose of eculizumab or ravulizumab. When you add in dinicapam, you get improvements in hemoglobin. Because of that improvement in hemoglobin, you get an improvement in their fatigue scores, a reduction in their reticulocyte count, and over 80% of the patients not requiring transfusions. So what about iptacopan? So iptacopan is an oral treatment, an oral alternative to which has an increased incentive for a lot of the patients that we treat. A lot of the patients don't want needles, whether it's intravenous treatments or subcutaneous treatments. And iptacopan is a selective factor B inhibitor. Again, targets the alternative pathway, which is always on in the body. By doing this, again, it prevents intravascular hemolysis without causing extravascular hemolysis. So it was initially looked at in 10 patients with suboptimal response to eculizumab, and because of the benefit in those 10 patients, there were 2 phase 3 pivotal studies. The APPLY study is looking at iptacopan monotherapy in patients who were anemic with a hemoglobin of less than 10, and there was a randomization to either receive iptacopan or to remain on their eculizumab or ravulizumab. There was an analysis at 24 weeks, and then patients on C5 inhibition could switch over to iptacopan and then remain on that as a rollover program. The primary response endpoints were a hematological response, so an increase in hemoglobin of more than 2 grams per deciliter, and a hemoglobin increase to more than 12 grams per deciliter, both without transfusions. Secondary endpoints were transfusion avoidance, change in hemoglobin levels, FACIT fatigue scores, retic counts, LDH levels, and safety, so looking at hemolysis with breakthrough hemolysis and thrombotic events. When you look at the groups, they were largely similar. Importantly, around 60% of these patients, 60% of these patients were requiring red cell transfusions when going into the study. In terms of treatment with iptacopan, 51 out of 60 patients had an increase of more than 2 grams in their hemoglobin, as compared with none of the patients remaining on standard of care. And when we look at hemoglobin levels greater than 12 grams per deciliter, nearly 70% of patients achieved this, whereas that was only achieved in just under 2% of the patients on standard of care treatment. When you look, you can see again the speed of improvement in hemoglobin level following the green line on patients on iptacopan, and when patients switched from C5 inhibition to iptacopan, you can see again it quickly comes up and remains around 12 grams per deciliter out to week 48. So what about newer therapies that aren't readily available even in the UK at the moment? So because of the benefits we've seen by targeting the alternative pathway, MASP kinase inhibitors are certainly something to look at, and there's some good data to show by inhibiting MASP kinase, you're then inhibiting factor B function and availability. So just show you brief data on a very early phase 1b study. This looked at zaltinibert, so the product from Omeros. There was, you can see, a screening period, treatment period, and these are patients who had a hemoglobin of less than 10.5, an LDH level of more than 1.5 times the upper limit of normal, and were complement inhibitor naive. When you look at the outcomes at 12 weeks, you're getting a very marked improvement in hemoglobin levels. Now, this was much more so in patients who had who didn't have any evidence of myelodysplastic syndrome, the green line, but even in those who had MDS, you can see there's quite a marked improvement, which is sustained in their hemoglobin levels. So MASP kinase inhibition is certainly something that may be a useful product in going forwards, but we need to see phase 3 studies of that. The other drug that I'm going to mention is that of KP104. So KP104 has 2 modes of action. So it is both a proximal and a terminal complement inhibitor. So it inhibits at C5, but it also inhibits factor H. So by doing this, you could say it's similar to the combination of dinicopan and a C5 inhibitor, but it's in one therapy. Now, what we really need to see for KP104 is more patients treated, a phase 3 study in multiple centres and multiple countries. The data that we have seen, which is presented at ASH in the last 2 years. Last year was an update of the initial patients. Looks very impressive. You can see marked improvements, 100% of patients having a hemoglobin increase of more than 2 grams per deciliter. More than 80% had hemoglobin normalization. And all these 18 patients remained red cell transfusion independent. So it looks very impressive, but I think we need to see data on more patients. So in terms of what I would do for a naive patient presenting, in the majority, I think they are better off starting on a C5 inhibitor. I worry about people not understanding the severity of the disease and going on a tablet treatment and worrying about compliance. But for all patients who are naive, we would talk to them about ravulizumab, we would talk to them about crovalimab, and we'd talk to them about iptacopan. If they'd have a presentation with a thrombosis or a very significant thrombotic history, we would definitely favour C5 inhibition. If they have poor oral compliance, and some patients in the UK readily say they are not very good at taking oral medication, again, we would go away from iptacopan and go with a C5 inhibitor. And we would reevaluate them after 6 months, because it may be that we need to switch to a different therapy. So if they have a suboptimal response, there are merits to all the options that we could choose. So pegcetacoplan, it has the longest safety and efficacy data, because it's the drug that's been around the longest, but it is a subcutaneous infusion. So we're reliant on patients self-administering, and it's a subcutaneous infusion that they have to administer twice a week. Danicopan we would tend to favour danicopan again if someone has a significant thrombotic history, or if they're not good with an oral compliance, because we know that if they don't take their danicopan, they still have that C5 inhibitor treatment inside them. But it does mean 2 therapies, so there's an additional cost by having 2 different treatments, and not all patients want an intravenous treatment and a tablet treatment. Iptacopan, for patients who are compliant with oral treatments, offers an opportunity for them not to have needles, whether it's intravenous or subcutaneous treatments. But it's important to counsel patients about compliance, about setting alarms on their phones, about getting in touch if they have vomiting, diarrhea. If they're not able to take an oral treatment, they need to liaise closely with their clinicians. And with that, I will stop. Thank you.